Good morning, everyone. I'm Larry Hanrahan. I'm the research director here at the University of Wisconsin Department of Family Medicine and Community Health. And today we're going to talk about a new program that we have just initiated, our rapid research program. And so our agenda today is to cover really the theory and practice of doing high-quality research very quickly, how we're going to staff this in our department and what the various roles are to make this happen. And then we're going to end with the spring cohort 2016, our first class going through this. And we'll give you an idea about what some of the topics are that they're going to research and where we are. So, rapid research. I know all of you've been engaged with Dr. Rabago here and thinking about research, and it's a team sport. It's hard to do. There's a lot of moving parts, and so, but we're now at this point where we have all of this big data, lots of data in our electronic health records and elsewhere, and it's just, sort of sitting there. It's low-hanging fruit. There's a lot of answers there that can come from it. So the big idea is to use big data and use our electronic health records to answer questions. And so it sort of has to be in that data set for the rapidity to work. The other way that we make this a very rapid process is to standardize our approaches and as much as we can begin to automate and learn from the process so that after our first cohort goes through, we will have learned quite a bit and developed algorithms that we can use on the big data for subsequent classes, and so that increases the velocity. And so the very exciting thing about this is that this is actually a tried and true process that does work. This is based on a program that was developed by Dr. Jeffrey Scherer at the University of St. Louis Department of Family Medicine, where they used big data, created a support team around investigators to get research results out quickly, and we'll talk a little bit more about that. So you're probably all familiar with Pico, and so this is really at the heart of it, that we assemble a team around a principal investigator, a physician, to examine the patient problem or population, the intervention and comparison group, and outcome. And really all of this leads into the first part, or first step of doing a good literature review or a good systematic review. And so there's this paper published in 2003 that sort of outlines this quite well in terms of the steps to conduct. But what I really liked about the diagram here that they present is it sort of aligns Pico up to the study sample, that's the population, how the participants are allocated into an experimental group or a control group, or in our case it might be more one population or community population that's maybe experiencing a health, an economic or social disparity versus those who aren't. And then looking in our data to find out, so what is the outcome that we're interested in studying, and then seeing how does, analyzing that, how does that sort out, are people in poverty at higher risk for diabetes, for example, and are they also at higher risk in our clinics of not being as well controlled? And so that would be one example of working through this. So what we're doing here is powered by the Phoenix Project, the Public Health Information Exchange, where since we are now the Department of Family Medicine and Community Health, and as family physicians, we more so than any others in practicing medicine know the 80-20 rule of health, that 80% of the causes and variants of being healthy happen outside the clinic, and are not due to what does or doesn't happen inside the clinic and during healthcare. And so a key idea here is that we're not just looking at the electronic health record, but we seek to bring in information from the outside and link that to the electronic health record. And so in the case of Phoenix, we've been geocoding the addresses, and then from that we can link, well, is this person living in an area that has a higher poverty rate than others? And so, you know, we've done that. This is just an example. Again, to you all as astute clinicians, you essentially know this already, that we have two red circles, you know, high risk areas depicted here on this map, and then the one green circle, and these are circles of patient populations that come to 3 of our clinics. And of course, the red circles are areas where we have higher diabetes prevalence, and then we're doing a much worse job of controlling their diabetes compared to the green circle, where much lower prevalence, and we're doing a great job compared to the red circles. And then, so the other aspects of these hot spots is that they are, you know, areas of high poverty, economic hardship, less lower fresh fruit and vegetable consumption, et cetera. So those are kind of some of the kinds of things we can start to visualize with the data, and it illustrates this approach of bringing data in from the outside to see how that might relate to care, and give us ideas about, well, what might we do about this to make circumstances different and better. So the other thing that we're doing, you know, it's all about the velocity, you know, because research takes time. And so one thing that we are emphasizing here when applicable is that we will seek to create completely de-identified data sets and or formulate the question and process to be a quality improvement study. And so both of those are instances are IRB exempt, because in both instances they do not meet the federal definition of human subjects research. And so, not saying that we won't ever have to be involved with the IRB, but we're trying to emphasize this approach as one way of legitimately increasing velocity and study velocity and getting the work done. So, so this slide here I borrowed from my colleague Jeffrey Scher at St. Louis, you know, where he talks about, you know, what's the problem that we're trying to solve? I mean, in essence, the problem is, so we're in an academic medical center, and the expectation is not only do you see patients, but you conduct scholarly work. But the fact of the matter is that most clinicians are not formally trained in research methods. You all are very, very, very busy people. You don't have protected time to do research. And your passion, you're in medicine to take care of patients because that's where your passion lies. And so, you know, you may not have the orientation to research that someone, our other faculty, much less numerous, who have gone through, are in the tenure track where research is their passion. So, so there may be less excitement for research. And then finally, there's little time in your busy lives to actually field primary data collection, deal with the IRB, and manage all of the staff and project manage the whole thing. I mean, it's a team sport. And so Jeff has this really great quote, you know, because they did do this, they had a cohort of 5, they were very successful in their program, and one of the comments was from a physician saying, I did not go into family medicine to do research. I don't have time and I don't know what to research. That's sort of the incoming attitude. And then where they ended up was they enjoyed the research required to advance in an academic medical center. So, so this is again a slide from Jeff where it's from idea, conception to to the end, in 9 to 12 months, you get a paper submitted and published, which is, that is sort of lightning speed by today's standards. In his initial cohort of 5 physicians, they produced 10 manuscripts. And so, the steps are, month 1 to 3, you kind of have the idea and you do your literature review. Months 4 to 6, you work with your team and do the preliminary data analyses. So you get some output, and you maybe have to do a little adjustment at seeing how things are end up. So you maybe refine the question and then do a final analysis and do the write-up. And so in 7 to 9 months, you're ready to get that out and published. So how are we going to staff all of this? It sounds, anyone who's attempted research, this is nothing sort of, maybe magical thinking or trying to be, thinking about miracles. But so what we're doing in our program is we're providing 3% protected time for our physicians. The interesting thing here is I spoke with Jeffrey many times, and he said, we only need 20 hours or 1% of faculty time to do this. And we thought that was maybe cutting it close to the bone. And so we're actually trebling his estimate and saying we need about 3%, 63 hours. And the key to all of this is divide and conquer. Really turning research into a team sport. And so the expectation on the physician PI is to come up with the question, to be intimately involved and ideally actually doing the literature review, to do that Pico and frame the question. And then that results in terms of actually the writing tasks for the physician are sort of the introduction, the definition of the problem. And then the rest of the team does the heavy lifting of everything else, and then the physician comes back at the end and writes the discussion conclusion section. And so the other team members are myself, the research director. This is closely modeled after what St. Louis is doing. So I would be responsible for project management, making sure that the staff are showing up and that we're hitting our timelines. And then I would also be involved in contributing and overseeing the writing of all of the sections of the manuscript. Now we also have a data analyst on board as a part of this, and so their responsibility is to actually, take the criteria, extract the data that we need, and make it available then to the biostatisticians that we now have available. And so the data analyst would also be responsible for contributing to writing the methods section to describe how it is that we got the data and what the criteria were. And so the biostatistician then, so they do the actual analysis of determining what tables, graphs, charts do we need, what kind of statistical modeling that is done, and then they actually execute that and do that. And so then they're responsible for writing, in addition to the analysis, writing up the statistical methods, results, and then also producing the tables. And then we're very excited, we've just also hired a medical research writer, editor, and she's a phenomenal person. We're so happy to have her with us because she not only, in another department here on campus, played the role that we want her to play here, where she's going to help us get the writing done. She will serve as the editor to sort of backfill and backstop all of the manuscript sections. But then she'll also be involved with journal submission and revisions. And again, what's exciting about her background is this is what she's done. And she also managed the office for a journal that was, sort of on the other side of the fence, that they're receiving the submissions and then sending that out to reviewers and getting that whole process together. So she knows the whole business of this, on both sides of the table. And so we're very excited that, that she's with us. And she has some very good skills, too, in terms of keeping teams on track and getting the writing completed. So that's the new mix, and was actually the thing that we really purchased out of this whole program to start it up, was to bring her on board. It was half of it pays for her salary, the other half is to fund the protected time. So these are the, and I have also this handout which goes into a little bit more detail. So our first 5 faculty, we sent out an invitation, I think a month and a half ago or so, saying we have this program. If you're interested, just send us a couple of sentences and we'll meet with you and we'll start forming a team around you. And so Michelle Bryan is going to look at, ask the question of how does MyChart utilization impact work and traditional office visits. And this one really resonated with me because not only does it begin to change your workflow, but as we see more and more patients involved with MyChart, we can start to bring in more data from the outside, through patient-reported activities and outcomes. And so it's going to be interesting to find out how, what's the representativeness of people engaged in MyChart, and how does that also relate to their demographics and potentially how well they're doing in terms of their health. So that's a really important study. Matt Swedlin is looking at, as you probably have all are aware of, did the UW hypertension best practice alert impact blood pressure control in our patients? And he has a number of other specific questions where he wants to see, well, did people take action as a result of that? There's a number of ways that we can assess that in the electronic health record, as well as even see, well, did it matter? Did we end up getting people under control better? Ildi has asked the question, does hope and resilience overcome poverty and subsequent health disparities? And if so, how can teams increase patient hope and resilience? And of course, we don't necessarily chart those things at the moment, but we're going to be meeting with her shortly, and we have some really great ideas to begin to frame that up and really turn this into what I hope will be a whole research agenda for her and others. Irene Hamrick, of course, is very interested in the elderly, and she has done a lot of preliminary work looking at the potential relationship between dehydration and the risk of falls in the elderly. She's done a great literature review on that. We just met with her yesterday, and so her team is forming up, and this one is, I believe, going to be a slam dunk for us because she's really done a fabulous job of specifying the data elements and what it is that we're going to need to extract. And then finally, Elizabeth Perry is asking, is RN care coordination for depression as effective for patients with diabetes and hypertension as it is for patients without those comorbidities? So, all of these, this is a wide-ranging set of questions, and all of these do, in a way, ultimately relate to how do we do practical research in the sense of how can we use our data, look at it, understand the uniqueness of our patients, as well as how we practice in relation to them, and then how can we put this all in the mix, analyze it, and ultimately do a better job of taking care of our patients. So that's the first 5, and we're really excited that we're getting going. And so that's sort of the presentation. I also have, I handed out this sheet, and I also have sort of the timeline that we really started about fall of last year, talking about this, and then proposing to the Leadership Council, and they voted on this and a few other activities, and we got the green light to do this. We hired our writer. We have the funding now to do the set-aside for our faculty. And we're pretty much halfway there. We've got the staffing aligned, we've got our faculty cohort, and we're now at the stage of setting up these teams, and then we're going to start executing their study with them. So if you have any questions, I'd be happy to answer them, or if you'd like to discuss anything.
I'm just curious, like, on the ground, like, I'll just pick Irene's because it seems like it's a straightforward thing. Are you privy to, can you tell me this stuff? I'm just curious, like, how she's going to assess things like hydration, fall risk. They seem relatively straightforward, but I don't know how, like, what data elements and stuff, as just an example that you guys would pick out for something like that. That seems potentially very concrete as opposed to like ILDs, which I think is a lot harder to measure.
Right. So yeah, she has a really great data model, data definition, of basically, there are codes to chart whether or not a person had a fall, and then there might be other comorbidities that go with that, such as dizziness, or has the person had a stroke, things of that nature. And then of course there are laboratory tests that could be in the chart that give a sense of whether dehydration is an issue. And so again, there the limitations that we have are, well, it has to be answerable in the data, and it sort of has to be in the data. And of course, as you know, something like a fall, there are lots of falls that happen, and we don't know about them. And and of course, that's a limitation of this approach. But all things being equal, the question becomes, what. How does dehydration sort of play into that picture of the falls that we do know about?
I was looking at Matt's and thinking, it seems like pretty definitive in terms of there's an intervention with a time frame, and I could see things like you could see new prescriptions for people who are out of control at the time that the intervention happened. That seems relatively straightforward. For other types of interventions, like how do you work that with big data? Like if there's an intervention, I don't know how that happens. It makes sense from like an IRD, QI standpoint that it can pass, but I don't know how you do an intervention and follow big data. I don't really know how that works.
Well, yeah, I mean, it kind of comes down to what the issue is and what is the intervention, and again, I think because we are the Department of Family Medicine and Community Health, have to think bigger than just an intervention in our clinics, that it could be a way that we equip a patient when they leave our episode of care, that they change what they do for themselves. There's also the idea of we begin to engage with our communities and the neighborhoods and the organizations within these local communities that we serve to do things differently. And then, we can look in our data and at particular patients and see if that intervention has occurred. So, so I think the thing is that at this level, sort of the rapid aspect is really looking at different contrasts within the data, as opposed to that second step of, we're going to, do something different, intervene, and test. In the case of, and Matt's example is really perfect, because that was a natural experiment. We said we need to have these alerts going on, and so we can simply look at that and see, how well that worked for us. But I think, kind of coming back to Ildi, and I'm excited about what she's asking, because we can answer some things and look at some things that we really haven't for our population in a systematic way. And hopefully this sets the foundation for primary data collection, that it gets connected to the electronic health record, and then also is something that forms an intervention that we then test. And so the idea is we haven't really, for our population, systematically said, well, what is the impact of poverty in our patient population? And how does that relate to various conditions? And so I think that's a starting mark for us. And sort of within that is this idea that, well, there are both patients who are in poverty, who we know are at higher risk and are not doing very well, but there are also patients that we're seeing who are doing pretty good. And that's really her question, it's like, how is that happening? And then, so we can look at that in patients in, disparate populations, patients in poverty, and then also look at that in patient populations who are not impoverished. And then from that, I think the second research, sort of more research, primary data gathering research is, David's been doing this in some of his work. We'll build an app, and we can start sampling from these different populations. When they come in to see Ildi, we can ask them about resilience and hope, and there are some instruments out there. And we can actually see, well, does it matter or does it not matter? And then also, as we start doing that, we can ask ourselves, well, then, if it does matter, what are the things that we can do to kind of take that bright spot within a disparate population and turn that into the norm for the people who are not experiencing that? And so that becomes this whole, sort of research arc on poverty, hope, and resilience. And the first part of it is this rapid, let's look at what the data says about poverty, and then subsequently we maybe have a more formal actual research program where we gather additional data.
I think the interesting part of this is leading with what one is truly interested in, right? That's what Ildi comes to this with. Like, I looked at this question early in its submission, and it's like, oh, that's what Ildi really cares about. She's at Wingra, she's always been at Wingra, she cares about the underserved, treat the underserved, learn about how to help them the best. Some of them are doing very well, what's up with that? She didn't pause, I don't think, and ask herself, yeah, we don't really collect data on hope and resilience, never mind that, for a research topic. The key, I think, is to bring your passion to the table and try to frame this Pico idea from your passion, not the other way around. That slide on method that was busy and had the diagram, a flow diagram, and present, absent, that's a goal, not the lead. Like, you start with what you're really interested in and see if one can organize the idea into some kind of flow that can be analyzed. It's not your job, it's none of our job, to know what every single variable is. How many variables in the database?
I think there's something like 60,000 variables and counting.
Right, so I don't know those. And Larry doesn't know every one of those. They have to be searched for. We lead with what we love and see if it can be framed. I think that's really the key.
Right.
And that's the intimidating piece when one doesn't have a background in this kind of thing. It's like, what could I possibly do? So, just off the bat, osteopathic manipulation is coded for. Pain is often coded for. Opioid and other pain medications are coded for. One can imagine a flow diagram in which manipulation is or is not present. Opioids are or are not prescribed or going up or down, and so on. then that's just off, that's just from the hip.
I thought 2 others already.
There you go.
Right. I have a question.
Sure.
So my question was, is the patient survey data that they do also include?
To have it, yeah, that could be a part of it, absolutely. Yeah, and that would be a great add-in to what David was just describing, so do we have patient satisfaction
Right.
to go with that?
Right, that was one of my
Yeah.
questions, was, is
Yeah.
safety and patient satisfaction
Yeah.
correlated?
So I see I think I end up getting stuck a little bit on the back end of just getting stuck with thinking like, how do you extract that data? What data is available? So I'm thinking of like poverty. Well, we don't ask about income. Right? We always like beating around the bush and asking for proxies of poverty like address or their insurance type or whatever. So yeah, I get hung up on that all the time.
How do we come up with the right surrogates?
Right.
Well, and so you kind of mentioned the two obvious ways, so we do have the geocoding, and from that we can see, on an area basis that you're living in an area that is impoverished. But of course, areas change and gentrification and things like that. It's imperfect. The second best method currently would be insurance. Yeah, to look at, obviously, if you're on Medicaid, there's there's an income test that is applied for you to qualify, and so so the idea would be on the rapid side, these are imperfect, but we can start there, and we can look at maybe this tighter classification, looking at insurance. That's a one-to-one thing. It's for that individual, and an income test has been applied. And then we can also be more, a wider definition would be applying, what area are you living in, and is it impoverished?
Along those lines, like race and ethnicity questions, I think we're required to ask them at Wingrove. I don't know if anybody else is required to ask that, but I know we are because of our CHC association.
Yeah, we have that, and of course, one of our great successes in Phoenix was our first student that we worked with was Kevin Tao, and what was so awesome was, we went beyond race, ethnicity, and went to language translation services and found, a subset of about 1,000 people who had asked for Hmong translation services, and so, that's a big number of people to be looking at, and he had a great study and some great results from that replicated some of the things that are known with that population in the literature. So so there's a lot, it's sort of that's a great example of the bigness of the data. So if you would look at something equivalent like Show, and he's working on getting a supplement, so he's actively trying to get some sampling out of the Hmong community. That's a wonderful approach, but with absent getting those extra resources, you don't have a good sample space of that population. And then some of the other surveys like behavioral risk factor, you would never be able to go down to the Hmong population to study. So it's a phenomenal opportunity. Yeah.
All right.
Okay, well, thank you. Yep.